Endoscopic ultrasound-guided biliary access versus precut papillotomy in patients with failed biliary cannulation, a retrospective study. Introduction. Selective bile duct cannulation fails in about 10% of endoscopic retrograde cholangiopancreatographies, ERCPs. Precut papillotomy is commonly used when conventional techniques fail and allows for same-session biliary access in 65% to 85% of patients in whom standard cannulation has failed. Interventional endoscopic ultrasound (EUS) techniques allow for targeted access to the biliary tree for rendezvous ERCP or EUS-guided biliary drainage procedures such as antegrade transpapillary stent placement or creation of a new ductolumen fistula, e.g., choledochoduodenostomy or hepaticogastrostomy. Several centers have reported high success rates, greater than 85%, with these techniques after failed cannulation at ERCP. However, there are limited direct comparisons of EUS-guided biliary access and precut papillotomy. Additionally, the influence of these interventional EUS techniques on overall ERCP success is unknown. Lee et al. Hypothesized that incorporating EUS-guided biliary access in addition to precut would result in a lower ERCP failure rate compared with that of ERCPs performed using only precut papillotomy for failed cannulation. The primary study objective was to compare the failure rate for therapeutic biliary ERCPs performed with and without the use of rescue EUS-guided biliary access. The secondary objective was to compare the technical success of EUS-guided biliary access to precut papillotomy. To this end, the authors compared ERCP outcomes in two patient cohorts undergoing biliary ERCPs, one in which same-session EUS-guided biliary access or precut papillotomy was performed, and the other in which only precut papillotomy was available after failed standard cannulation. Background and study aims. Precut papillotomy is widely used after failed biliary cannulation. Endoscopic ultrasound, EUS-guided biliary access techniques are newer methods to facilitate access and therapy in failed cannulation. Lee et al. Evaluated the impact of EUS-guided biliary access on endoscopic retrograde cholangiopancreatography (ERCP) success and compared these techniques to precut papillotomy. Patients and methods. Lee et al. Retrospectively compared two ERCP cohorts. One cohort consisted of biliary ERCPs attempted in patients with native papillae and surgically unaltered anatomy in whom precut papillotomy and or EUS-guided biliary access were routinely performed immediately after failed cannulation. This cohort was compared with a similar ERCP cohort in which only precut papillotomy was available for failed cannulation. The following outcomes were compared. Conventional cannulation success, rates of attempted advanced access techniques, precut or EUS, precut success, EUS-guided biliary access success, and ERCP failure rates. Results. Although conventional cannulation success, rates of attempted advanced access technique, precut or EUS, and precut success were similar, the ERCP failure rate was lower when both EUS-guided biliary access and precut were available, 1.0%, compared with when only precut was possible for failed access, 3.6%. Success for EUS-guided biliary access, 95.1%, was significantly higher than for precut, 75.3%, and mainly due to superiority in malignant obstruction, 93.5% versus 64%. Conclusion. EUS-guided biliary access decreases the rate of therapeutic biliary ERCP failure. The author's results support the use of EUS-guided biliary access to optimize single-session ERCP success. In experienced hands, these techniques appear as effective, if not more so, than precut papillotomy.